Good day, everyone. I want to welcome you to the Setting Scoliosis Straight Foundations Eastern European webinar, Power Over Scoliosis. Next slide, Harvey. My name is Harry Shufflebarger, formerly of Miami and currently of the Paley Institute in Palm Beach, Florida. My co-moderator is David Clements from Cooper Bone and Joint Institute in New Jersey. Next slide. We have a distinguished faculty of guest surgeon speakers. We have Salil Upasani from San Diego, California, Dr. Yilgor from Istanbul, Marco Brayda-Bruno from Milan, Italy, and Vasil Yablanski from Sofia, Bulgaria. These are the four faculty, and they will do an excellent job. Next slide, please. And we have the treat of two guest patient speakers from Eastern Europe. We have Miray from Istanbul, Turkey, and Ioanna from Sofia, Bulgaria. And they'll tell us their stories of their adventure, of their trip through scoliosis treatment, how it was, and how they are today. They're two charming ladies, and we're eager to hear their stories. Next slide. If anyone in the audience has questions, you can submit this through the Q&A function on Zoom. This is on the bottom toolbar. Just click on Q&A and type in your question. The presenter will then answer your question at the end of his presentation. It's very simple and easy to do, so please take advantage of the Q&A function. Next slide. This is the agenda. Our physician topics are Scoliosis 101, to be followed by the patient story, and then growth modulation, in particular VBT, which is the hot topic around the world these days. Then selective thoracic fusion, then treating scoliosis in Europe, our final patient story, and a few concluding remarks. And we'll try to keep on time, but have time for your questions. Setting Scoliosis Straight Foundation is a not-for-profit established about 4 years ago. It was previously the Harm Study Group Foundation. Our mission is to better discoveries and advanced techniques in the treatment of scoliosis in children and adolescents around the world, with the vision of a future where children with scoliosis have the ability to live healthy, happy, and productive lives. Setting Scoliosis Straight has sponsored basic research in scoliosis since its inception, and has an admirable amount of podium presentations and peer-reviewed publications, and the work will continue. Next slide. So we'll begin our presentations with Salil Upasani, who's Associate Professor of Orthopedic Surgery in the University of California at San Diego, and he practices at Rady Children's Hospital in San Diego. He's the author of a very impressive number of peer-reviewed publications in spinal deformity, and has presented around the world on this topic. Salil?
Great, thank you. Thank you, Harry, and good morning to everyone from San Diego. It's my honor to be part of this faculty, and I'd like to just spend a few minutes talking about adolescent idiopathic scoliosis to make sure we're all on the same page. So just to begin, what is scoliosis? So it's a three-dimensional deformity that develops in the spine. The images on the left show a straight spine in the coronal plane, so when you're looking at it from the front, and the typical curvature that you see with kyphosis in the thoracic spine and lordosis in the lumbar spine. compared to the three-dimensional deformity that you get with scoliosis. And while we don't know exactly why scoliosis forms, there have been changes in the bones, the muscles. A common pathway that most of these patients have is that there's some anterior overgrowth of the spine. So if you break the spine up into the front and the back components, we've seen that the front part of the spine seems to grow faster than the back, resulting in this three-dimensional twist of the spine. And so some of the treatment options, especially vertebral body tethering that we'll talk about later today, we'll talk about growth modulation or trying to slow down this anterior overgrowth. So first of all, to take a step back, AIS, or adolescent idiopathic scoliosis, is a diagnosis of exclusion. So when patients come to our clinics for curvature in the spine, there's a long list of conditions that we want to try to rule out. For example, underlying conditions like neurofibromatosis or Marfan's, which can all cause curves in the spine, changes in only the sagittal profile of the spine or kyphosis, such as seen in Sherman's, or other causes of back pain and back curvature, such as tumors or spondylolisthesis. So a close examination is really important. Also of note, it's important to note that many of these patients do come in complaining of pain. About 35% in this study that was published in JBJS in 1997. Some of the common sources of pain in children with AIS include subscapular pain from the rib rotation, muscular flank pain to deal with a compensatory trunk shift, or if there's a spondylolysis present or a stress injury in the bottom part of the spine, sometimes kids can have pain with hyperextension. When we're first examining these patients, we're looking at how the shape of the trunk is. So we look at the shoulder asymmetry both from the front of the body as well as from the back. Oftentimes, patients present with an asymmetry at the waist, or for example, in this picture on the right, where you can see that the trunk has shifted over. And it's important to carefully examine the skin to look for some of these signs that could be indicators of an underlying condition and not just idiopathic scoliosis. We also look at how flexible the spine is. This test is very common. It's called an Adam forward bends test, where we're looking at the rotation in the trunk as well as in the lumbar spine to look for any areas of prominence, and then a close motor and sensory exam to look for any neurologic abnormalities. Oftentimes we obtain x-rays. These are called standing views, looking at the spine from the front and the side. And we're looking at how the cervical spine lines up with the remainder of the body. Again, looking for any asymmetries and how the shoulders or the trunk is lining, as well as some rotation abnormalities that you can see present based on how the shape of the vertebral bodies look. If we're planning to take the patients to surgery, oftentimes we do flexibility radiographs, which are bending x-rays either with the patient supine or standing. And in some centers, we get traction x-rays to see how flexible the curve is and to help plan our treatment options. Also very important when treating children with scoliosis, we have to see how skeletally mature they are, because a lot of our treatment options are based on how much growth is remaining and how much we expect the spine to increase in magnitude as the child progresses in age. A very common measure right now is called the Sanders stage, which is based on these hand x-rays and all the growth plates that are present on the bones of the fingers as well as the carpus. And then some of these other ones looking at Risser sign, which is a growth plate on the top of the pelvis, or looking at how the elbow or proximal humerus, which is the arm bone, how that's developing will tell us the bone age of the patient. So sometimes we get an MRI in patients with scoliosis. Oftentimes this is for atypical curves. For example, if we see a sharp angulation or increased kyphosis or forward positioning of the spine. And of course, if there's any neurologic abnormalities or we want to rule out some of these other conditions in scoliosis. If we have male patients with adolescent idiopathic scoliosis, for some surgeons, that's an indication to obtain an MRI. And we're basically looking at how the neural axis of the spine is developing. So to look for any abnormalities at the base of the brain or within the spinal cord itself. I think an important point to make here is that the psychological assessment of children, especially female patients that come to us with scoliosis, is really important. Most of these patients present in their early teens, and as it is, it's an important time of growth and change. So having some changes in the shape of the body and the spine can definitely affect the psychological profile of our children. And it's also important to see what type of expectations the patients as well as their parents have in dealing with this alignment. So some of the treatment options that we're going to talk about today would be brace treatment or scoliosis specific exercises for children with smaller curves or with a larger growth potential. And then posterior instrumented fusion, which is the gold standard to treat large curves, as well as some of the growth modulation techniques, such as vertebral body tethering. So that's just a quick introduction for scoliosis, and I'd be happy to take any questions. Thank you.
See, there aren't no questions open now, so I have a question for you.
Sure.
The Schroth exercise method is wide, has a wide presence on the internet, makes a lot of claims. Do you have any experience about this and any thoughts about Schroth therapy?
Yeah, thanks, Harry. So I think there is a lot of work being done with Schroth. So these are scoliosis specific exercises that are trying to focus on breathing and flexibility of the spine, as well as the diaphragm, to try to control the position of the body in the spine. I think some studies have been done now that show them to be a good surrogate or as a complement to brace treatment. I think they work well in patients that are being braced to try to control curve progression. I haven't seen exercises alone to be so successful by themselves, but I think under the close supervision of a physician and a surgeon, I think it could work to try to minimize curve progression for kids that are being braced.
So it's not going to be harmful, number one. Number two, core strengthening type exercises are always good. And three, don't be deluded that it's going to prevent your curve from getting worse or make it better. Does that sum it up?
That sounds great, yes. Looks like we had a question from the audience about getting a copy of these slides, and we'd be happy to share those through Setting Scoliosis Straight.
I have another question then.
Please.
There are quite a number of scoliosis braces around that are touted to be successful. There's one category of nighttime only. The second category, the Boston brace was the initial one probably, which allows us to wear it at night as well as a certain portion of the day. And the Rigo Chenot and its modifications have recently been touted to be better than anything else. Can you speak to those three areas of bracing?
Sure, yeah. So I think the kind of the most quoted study that you would find is the study completed by Dr. Weinstein, where he looked at the traditional Boston brace and showed it to be extremely effective in controlling curve progression, especially if it's worn, more than 16, 18 hours per day. So I think that's our gold standard. The 3D braces have definitely become more popular lately, and we've done some 3D imaging studies to see if we're getting significantly more correction with those 3D braces. And the EOS imaging, analysis of the three-dimensional views shows that those braces do have some benefits in improving the coronal and sagittal plane, but we don't see a whole lot of derotation of especially the apical segments in the 3D braces. But I think that's still a question that needs to be studied further. And I think we're all working towards getting better correction and better compliance of our patients with our bracing.
May I? Just a comment?
Please. Of course, please.
Because in Europe, we got a lot of tradition in bracing, much more than the US. And finally, using for example, the Chenot brace that was mentioned by Harry, I have to say that the results are very encouraging. I have a long story, more than 30 years of treatment with the braces. And I have to say that the importance of bracing within a certain number of cob angle is important to keep the curve stable or reduce a little bit the severity of the curve, the initial severity of the curve. I am not so concerned about derotation with the brace because unfortunately cannot be achieved. I believe that because in a three-dimensional deformity, you are going in lordosis, so it can turn inside the brace. The important thing is to reduce the amount of the cob angle, the curve degree, and at that point, if it will stay stable at the end of growth within certain number of degree, we know that below 30 degree of angle, an adult spine can survive without basically major progression. And then this is the goal, trying to keep the curve at the end of growth below 30 degree of 35 degree of cob angle.
I think we would all agree with that. Thanks, Mark.
Yeah, excellent.
We have a question from a gentleman in Mumbai, India, who had a petite 11-year-old daughter who was recently diagnosed with AIS curve of 50 degrees. The doctor in India advised surgery, and he wants to know if we agree and where should he get it done. Salil?
Oh, Harry, you're putting me on the spot. So I think my first response would be that there's no urgency. Definitely when curves reach 50 degrees, that's typically when we start talking about surgical interventions, because the longer term studies have shown that these curves will continue to progress. And especially in an 11-year-old, you're worried about this curve getting bigger. You know, where to go, obviously there's fantastic centers throughout the world, throughout the United States, or everywhere. So I think finding high volume surgeons and Setting Scoliosis Straight is a good resource to find those types of surgeons close to you. What else? Yeah, so we're going to talk about a few of those treatment options. You'll see some selective fusions. You'll see some vertebral body tethering, which might be an option as well for a 50-degree curve in an 11-year-old girl. But yeah, I think if you contact us after this webinar, we'd be happy to get you connected with good resources to take care of your daughter.
Okay, we have one other question. Do you suggest Barcelona physical therapy for a 10-year-old kid with 23 degrees of scoliosis and wearing a brace 16 hours a day? Since probably neither Salil nor I are familiar with Barcelona therapy, I'm going to ask Marco to answer that.
Yeah.
I got you off the hook there. So.
Thank you. Marco, do you have any experience with Barcelona PT?
No, I don't know, frankly, I don't know the Barcelona kind of exercises. Nevertheless, I think that the most important thing is to have a part-time bracing and to be followed. That is the most important thing, is to be followed. And with the EOS imaging, we can also follow with more X-ray than before, knowing that there is a low dose X-ray technique. And then this helps us also to make several screening with X-ray to understand if the curve is going to progress or not, if it is responding to our treatment.
Yeah.
Exercises could be important combined, in my opinion, to the bracing, not alone.
Yes.
Okay, I think we'll close the question session there. And I'd like to introduce our first patient guest speaker, who is Miray from Istanbul, Turkey. She's 19 years old, and she had scoliosis surgery about 8 years ago, and she'll describe her experience. Miray?
Hi, my name is Miray. I am 19 years old. And today I want to talk about my scoliosis life. But before to begin, I want to tell a story I have been through a few weeks ago. I went to a tattoo studio to get a tattoo on my neck, and the guy looked at my neck to position the tattoo. Then he said, "Oh, you have a scoliosis." And I said, "How did you know that?" His answer is, "I study anatomy so I can understand a little." So I thought scoliosis is a part of our lives, even when get a tattoo. That's why we need to escape scoliosis, and I did. I escaped scoliosis before the surgery and after the surgery, all my heart. So scoliosis is part of my life, and scoliosis has a cure, and very good doctors help us so get through this. So we are very lucky. That's it. Actually, I'm scared before the surgery, but I said to me, everything will be fine. You have a good doctor. You are lucky. That's it. I trust all of things. Just that.
Miray, can I ask you a question? This is Dr. Clements.
Yes, sure.
So did you tell your friends that you had scoliosis?
Yeah, I
what-
told them.
Did you tell them you were going to have surgery?
No, actually, I'm so little, and I didn't tell my friends because I just get embarrassed myself to get a surgery. But then it's just so normal. Then I tell them I had a surgery.
So if you were, you were probably frightened before the surgery. Did you talk to someone about being frightened about going to surgery?
Actually, I'm not frightened at all when I thinking now, because I know something will be fine, very fine, because like as I said, I'm the first one in Turkey. I had a surgery like this, and I just proud of myself because I'm first. I'm so brave. I don't know. I'm not scared so much.
And how quickly did you get back to doing things that were normal, like being with your friends and playing sports?
Everything will be fine. I can play basketball. I can swim. I love swimming, and I was a professional swimmer, but I'm not now. But I have a ache in my back and before. Now everything will fixed. So
That's wonderful. Well, you're very brave, and you were very eloquent in describing how you went through this. Do anybody else have a question for Miray?
So David, this is
Just a comment. Sorry.
Yeah, so I just want to also comment. So Miray was operated by our team with Dr. Ahmet and myself. And she was really very brave. So she was the first patient getting VBT in Turkey. Actually, it was also outside the US as well. So we started so early that, only 3 centers were doing this in the United States, and we were like the 4th in the starting this in the Europe and all outside US. And we were very open in discussion with Miray and his mother about being that they would be our first case, and so they were comparing it to what results they can get. What are the expectations? Actually, we didn't know as much as we knew then, but we told them about all the information we had until then, and they underwent the surgery, and she had a good recovery, and she is here 8 years off, still doing great. So I want to also thank her for joining and taking the lead in this.
Yes, thank you so much, Miray. It was wonderful to have you. It looks like you've done extremely well. So I guess
just a comment. I have to say that only the professional sport guys can be brave like that. I know everyone that is making professional sport, they are very brave.
Very true.
Thank you
so much.
Very true, Marco. And so I would like to formally introduce our next speaker, Dr. Caglar Yilgor from the Istanbul Spine Center, who's going to discuss to us about VBT or tethering surgery, which many people have heard about.
Thank you, David, for the introduction, and thank you for having me. So I want to talk about two things here. First, I want to talk about growth modulation, and I want to talk about scoliosis. And doing that, I want to split my talk into two. In the first half, I want to talk about, the mentality that bring us to VBT, and then in the second half, I will actually talk about VBT. So scoliosis is where it's on the spine, and the spine is made of vertebra, and we are animals that are categorized under vertebrates. So what are vertebrates? If we ask Google, which we ask all the time about the things that we don't know. So these are a type of animals that are mammals, birds, reptiles, amphibians, and fish. And here you see the first ever known vertebrate, which lived almost 500 million years ago. And much things have changed after that. And today, again, as Google says, we have almost 70,000 different species that are described as vertebrates. And looking at these 70,000 species, if you look at the anatomy, an extinct, reptile from 260 million years ago, and the domestic cats that's living in your house today have pretty much the same anatomy. And this is a mammoth from 80,000 years ago. And if you think you are very special, just compare yourself to a snake. You are pretty similar, I guess. So the bottom line here is that, the anatomy as the discs and the ligaments and everything has been pretty much the same for 250 million years. But the function has changed tremendously over the years, the way we use our spine, because we have a lordosis in our belly, which no other vertebrate has, and because that's the way our pelvis is shaped, we are the only living vertebrate species that have a spine that's loaded under a posteriorly directed shear forces. So the second thing is to look at the growth. So in a chart like this, comparing age and the growth velocity in years. So in the early 3 years of our lives, we grow tremendously, and then we grow less during the childhood. And then during adolescence, we then grow again. And how we do that is through growth plates. And these growth plates are also within the vertebra in different positions as a ring of apophysis. And the funny thing about growth is that applying forces outside, you could actually change the way you grow, like these ladies in China do with the foot binding, or the ladies from Myanmar in Padang women, they do with their necks. So the mentality that we have known up to here was that our spine, the way we use it, has created a unique loading pattern, and that our growth plates are susceptible to loads that are acting on them. So looking at this in a setting of a study, people have shown that if you apply compressive forces posteriorly directed, you would create a rotational force because of the positioning of the facet joints. And we know today that if you have excessive anteriorly directed shear forces, you would get spondy. And if you have excessive axial forces, you would get Schurmans. And then excessive posterior forces lead to scoliosis, as was described by Salil as well. But the funny thing I found about scoliosis is that it starts in the sagittal plane and then in the axial plane. And actually scoliosis is the last finding of scoliosis. And this is done through growth plates, and the growth asymmetry is happening in the sagittal plane, axial plane, and also in the coronal plane. As we have known, this is going through a vicious cycle, and our body, vertebral bodies, the shape and the ribs, they all change. So scoliosis in this sense is not a postural disorder, but it's a growth asymmetry. And if we can find a way to change how the spine is loaded, then we can actually modulate the remaining growth that the patient has. So we can do this in two ways. We call it direct and indirect spinal growth modulation. And indirect growth modulation is what we have just been talking about, the physical therapy exercises and bracing. If we can, with a brace and with exercises, can change the load distribution like this, then we end up changing the way a kid grows. So this is done with breathing, as Salil has explained, and through 3D correction and elongation. So this is actually for smaller curves that it's alone enough. But in some rare cases, if the patient is very flexible and if you can get a early in-brace correction like this, where you can correct almost fully the rotation, almost fully the cob angle and the sagittal plane, with the breathing mechanics as well through braces like this, asymmetric braces, you could even get, scoliosis correction through indirect growth modulation. And again, this would change in the sagittal plane. So here are also some very extreme examples of bracing, very big curves, but very flexible to start with. So this was why we were able to modulate the way they grow indirectly with braces and also with exercises. But the real majority of the patients are that with bracing and with exercises, generally they are not enough if the curve is too big or if the curve is too rigid. And generally they are not enough in the time that's remaining with the growth. So here comes the VBT with a direct growth modulation. It's applied directly on the vertebral body. So we have now more forces that we can apply. So we can do more modulation in a smaller time period because we have more loads acting, and it looks like this. And when you tighten the tether on the convex side of the spine, you get modulation of growth through time. And this is true in changing curve size, but this is also true in at least some of the patients in changing the way our vertebral bodies are shaped. So by also, changing the position in the sagittal plane, we also try to play with the anterior spinal overgrowth as well. So in many cases, this is done thoracoscopically, but there you can also do it open ways, but we do it with the ports that you can see here like this through small incisions. And we have a team of spine surgeons, thoracic surgeons, and cardiovascular surgeons that are doing this simultaneously together as a team. And the main mentality is to understand how much remaining growth there is, and we are using all these signs to understand that. And in a study, what we have shown was that there are different groups of patients that as they are operated similarly, they would get different amounts of correction or growth modulation throughout the time, which we have placed our recommendations upon, which also affect the rate of complications. So I'll show one example of each Sanders case. So this is a Sanders 2. We know the patient is going to grow a big amount. So this is what we do, smaller correction in the table and try to leave more room for the remaining growth to change the way the vertebral body is oriented. And then these are her clinical pictures. So this is Sanders 3 now. The patient is a little bit more mature. So we do a little bit more correction and leave, again, most of the correction to the growth. And these are her clinical appearances. And now we go to Sanders 4. So now we try to correct more and more on the table to leave less for the remaining growth. And these are her clinical pictures. Now we go to Sanders 5. Now we are getting less and less growth. So this patient grew like 4 centimeters. And the change in this the cob angle was not very prominent. And these are the clinical pictures. And now we go to Sanders 6. Again, some growth and some changes in the vertebral body shape. But then we got a tether breakage. But luckily with exercises, this patient was still okay after the breakage of the tethers at 2 levels. And these are her clinical pictures. And now we go to Sanders 7, again, with minimal growth that's remaining. The patient has very similar cob angle after the surgery. And these are her clinical appearances. So we also have some examples where we use both the indirect and direct growth modulation techniques together. Like in this case example, Sanders 2, we don't want to operate, we don't want to overcorrect. So we first do the brace and then wait 6 months to allow for some growth and some modulation in the lumbar curve. And then we do only a single vertebral body tether on the thoracic area. And these are her early postoperative clinical appearances. So in general, the advantages are the motion sparing and growth sparing and rapid recovery. And the disadvantages would be that we don't know the long-term results. In most of the cases, we end up with less correction compared to other fusion techniques. And there are the pulmonary complications that are occurred that we should be aware of. And that this may necessitate multiple surgeries because of the overcorrection, tether breakage, and there may be conversion to fusion. So the take-home messages of this talk is that lumbar lordosis is unique to us, the way we stand with a bipedalism, with our hips and knees are extended, but this makes our spine rotationally unstable. And we have a coronal plane deformity. We always talk about it, but it's not the initial finding of the scoliosis. So however we treat it with braces, exercises, or surgery, we should change something in 3 planes in all patients, and that we can modulate the remaining growth of the patients indirectly or directly with VBT. Thank you.
Okay, thank you for a great overview and presentation of bracing and VBT. I think we're going to omit questions at this time. We're a little bit behind. Anyone in the audience who has questions, please submit them by the Q&A function, and I or someone else I'll answer them to start with. Our next speaker is Dr. Marco Brayda-Bruno, previously of Bologna, now of Milano, and a longtime European expert in spinal deformity. He's going to talk about selective thoracic fusion. Marco?
Yes. Do you see my screen?
Yes.
Yes. Okay. I thanks Dave and Harry to tell me to talk about selective thoracic fusion. The indication for this kind of surgeries for the lengthy type 1 curves or the old major thoracic curve. And I would like to share with you my team fusion area 3D planning, evaluation of the bending films to see the vertebral detorsion and the possible disc horizontalization, as well as controlling very well the sagittal contour for the upper instrumental vertebra and the lower instrumental vertebra selection, always covering the thoracolumbar junction. I will never stop in T12, for example. And our instrumentation strategy is based on hybrid constructs, mid-density instrumentation, and a lateral and posterior apical translation by sublaminar bands. So this is a case of a 11-year-old girl that has a menarche at 9 years old. So he got a conservative treatment with brace for 2 years, but there was a progression with apical torsion. And this is what is the shape of his spine when she went for surgery. He was 62 Cobango thoracic with a thoracolumbar flat back. I was just to point this as to help the selection of the fusion area. And you see that was a stiff curve in lateral bending. So this is the result with the selective T2L2 fusion. And this is you see the very nice correction on the apex using the sublaminar bands on the concave side, and also that help also either to derotate the vertebral body as well as to reconstruct a more physiological shape in lateral, in sagittal view with a nice kyphosis compared to the pre-op. This is another case with a less severe curve, 46 degree, with still Reser 1. So it was still growing, but you see here also in the sagittal plane how flat back is, in the apex of the curve. And again, in this case, making a selective thoracic fusion T5L1 was enough to readdress the spine and helping also the lumbar spine to be less with less rotation and having 5 disc free for future life. And this is also possible sometime also in young adult patients that has a progression also after the end of growth. And this is, we try to be as selective as possible with the lower instrumental vertebra in L2, leaving their 4 disc for motion. And we use again hybrid construct with the proximal loops as we do always, and sublaminar bands to translate and recreate a nice kyphosis with a very strong lever arm on very strong rods like the rail rods. So why we use sublaminar bands? Of course, our rationale is to use them when it is impossible to use other spinal implants. There are some cases of neurofibromatosis as well as osteomalacia, when we need a very important translational effect on the apex, and when we need also to distribute our corrective forces to avoid the pull-out of implants. Of course, this is a versatile, and solid fixation help for this translational effect, either lateral as well as posterior, to restore some kyphosis. And we can distribute the corrective forces, and we have also possibility to stabilize the spinal segments also far from the rods if it's not possible to reach the implants. Just to enter in the discussion that we are talking about the vertebral body tethering, I want to show this case that we did, in 2004 in a girl of 16 years old. We do this since, as you see, many years with the fusion. And in this case, of course, we can try to restore some kyphosis in this flat back of this girl. And as you know, with very little incision on the skin. But in this case, you see also from what we obtain from a cosmetic point of view. And actually, I saw this girl now this woman that is now 32 years old, and came to me a few months ago because he is pregnant. So this is my question to all of you: if we have to convert completely to an anterior vertebral body tethering when there is still some problems. We did in the past, the anterior vertebral body stapling, always for a non-fusion technique to allow growth modulation through the convex compression. There was the stapling that I know Dave was aware of what the results can be obtained. And now there is the vertebral body tethering that are always approached by a minimal invasive approaches, but only in still growing spine. And I want to really discuss with you the drift for this non-fusion technique that now are applied more and more in young adults, and where the growth modulation is already gone. I also want to introduce to you my way sometimes also to have a growth modulation to a distraction-based system that is going to distract the concavity, allowing them to grow and to have a periapical concave distraction implanted through a posterior unilateral approach, and through with this self-adjusting 3D motion being a motion preservation procedure, but only in still growing spine. This is some cases of mine with this T5, T12 distraction based with a good result at 2 years. And this is again a follow-up of almost 2 years. And you see the distraction, the self-distraction that you can achieve during time, making your daily life and sports. The relative advantages of this growth modulation posterior system is that it's a very short surgery, 90 minutes more or less, using 3/4 screw, a unilateral elongation rod, no ICU, short hospitalization to 3 days, and immediate mobilization with exercise, like in this case that I show you the picture. There was still, the medication, the posterior medication. We don't need thoracic anterior approach that needs drainage, ICU, and potentially can lead to peri-op and post-op pulmonary complications. And in case of implant-related complication that the SRS booklet for early onset scoliosis talk about up to 41% with the use of vertebral body tethering, they can be addressed, the complication of a posterior non-fusion device, by the same posterior approach instead of a risky anterior revision or a posterior fusion to stabilize the spine with 2 approaches to finalize the correction of the scoliosis. This is just my contribution to the discussion, and I thank you.
So thank you very much, Professor Brayda-Bruno. I have a question for you. So the people talk about doing tethering to maintain flexibility. How much flexibility do you lose by doing a selective thoracic fusion? In other words, how flexible are you after a fusion compared to where you were before?
Well, Dave, my consideration on this perspective is if you leave as much lumbar disc free as possible, then you can still have a very good mobility during life. When we are talking about making a fusion up to L1 or L2, in some selected cases, you have between 5 to 4 free discs moving. And this is very important because you know that when a thoracic curve will progress during adulthood, it will, of course, produce a progression also of the lumbar curve with a rotation of the lumbar curve, and this will bring to big problems of back pain and the progressive deformity that at that point would need a long fusion all over the spine. So in my opinion is that after 30, 35 years old, our thoracic spine will become more and more stiff. And at that point, really, we don't need to have a very high flexibility of the thoracic spine, but we need flexibility of the lumbar spine. And this is another point.
So how quickly after the selective thoracic fusion do you think patients should go back to doing their normal activities like sports?
Well, I advise to do swimming after 30, 40 days if the scar is well healed. And then they will begin to do normal activity. Of course, they cannot do professional activity. I try to advise to avoid jump like or big flexion like you know, artistic gymnastic and so on. But basically, they do almost everything that they are happy to do. After I just now have to control only the fusion at 6 months if everything is stable with the bony fusion. Okay, as I did also for the case I show you from the anterior approach. I did one of the case I did with an anterior fusion. I have still some question with myself about the tethering, and it is not a problem of approach. It's not a problem of how to do the surgery. I saw that I congratulate with Caglar about their results. I know Hamet Alanai since many years, and I agree with them that there is an interest and it must be follow this kind of surgery. I begin to use also in a few selected cases, but I am also concerned about the broad use of this technique because it's no fusion. It's not as a growth modulator, but just because we are not fusing the spine. And if you use in a young adult, as I see here, also in Italy, there are some that are doing surgery at 23, 25, 28 years old women. I have to say that this is totally off-label, in my opinion. Okay. We cannot talk about growth modulator anymore.
Okay. Well, thank you, Dr. Brayda-Bruno. We appreciate all of your insights and your developments. Next, I'd like to introduce my dear friend and colleague, Dr. Vasil Yablanski. Dr. Yablanski came to scoliosis surgery through a unique pathway. He trained as a joint replacement surgeon for older people, giving them new joints. He trained in the United States and went back to Sofia, Bulgaria, and now runs one of the most well-known and respected arthritis joint replacement surgery centers in Eastern Europe. Unfortunately for him, about 15 years ago, 2 American surgeons came over to Bulgaria and asked him if he would start a children's spinal deformity center completely different from anything he was doing at the time. And Dr. Yablanski not only said yes, he and his team have now developed one of the most premier spine centers for children in the Eastern Europe, and the only children's spine center in Bulgaria. And it's run completely independently. We visit them now just to see how well they're doing. So I'd like to introduce Dr. Yablanski to talk about what it's like to start a spine center in Eastern Europe, basically from nothing.
Okay, hello everybody. First of all, I would like to thank you for inviting me to be a speaker in this event. I hope you can see my presentation. Yes. So the topic that was given to me was treatment of spinal deformities in Eastern Europe. So Eastern Europe is a big area. I mean, it's a big term of many countries are part of Eastern Europe. And I decided to speak for our experience, the history of the scoliosis deformity surgery in the last years in Bulgaria, believing that Bulgaria is a quite typical Eastern European country. So in Bulgaria, we have a traditions and history for spinal surgery. And it starts from the end of the first report for spinal surgeries was done at the end of the 19th century. And afterward, during the 20th century, there were good progress, good development of the surgery with a very challenging cases and progression in the course of the time. And I would say it was up to 1990s when, you know, some changes happens, speaking about political issues, changes of the structure of the society and so on and so on. And after that, between the 90s and after the 90s, I would say this kind of surgery became on a standby or even in regression. And during that time, a lot of very old techniques were still in use. As you can see from the X-rays that I'm attaching to that are presented on this slide, very old techniques were still in use with quite poor results, poor correction. These are at that time were in use even some local implants produced in some unknown places, and there was no financing of the implants, which is a huge problem. As a result, patients were very scary, and it was very difficult for the families to take decision for surgery. And as a result, we had at that time very neglected cases. That's why in 2006, Scoliosis Research Society was invited by an international organization to visit Bulgaria to evaluate the condition of this kind of treatment and the condition of the healthcare conditions for children with scoliosis. And first visit was done by Dr. Buachi Ajay, Dr. Steven Margetko, and Dr. Paco Sanchez from Spain. So three of them are more than well-known surgeons. I mean, they're worldwide known surgeons. And they decide, and SRS decide to start an educational training program. And Tukuda was chosen. This is the hospital that I'm working. And as David said, until that time, none of us were working pediatric deformities. I was doing mostly hips, knees, and some other reconstructive surgeries in adults. The program was run by 2 to 3 times visits to Bulgaria from distinguished international surgeons. There were equipment donation, which was very important at that time. And the local and international teams were working together we've been trained and taught by these leading surgeons, which was an honor for us to have them in Bulgaria. What else? SRS sponsored many young doctors to attend some international meetings, what also was a great benefit. And they showed us how important is the health promotion among the parents. I do not have choice. I have to mention some names that are part of that are still part of this program. Dr. Steven Margetko, thanks to him, this program continued running through the years, thanks to his energy and his willingness to sacrifice time, efforts for supporting the program. Dr. Paco Sanchez Dr. David Clements, who can see on some of the pictures that I'm attaching here, and we're honored to be part of this meeting. Dr. Ioanna, the doctors Munition Fernando Gupta from the States, Stevens Richard and Peter Sturm. Also to emphasize Alexandra Marchese, she's an intraoperative neuromonitoring technician who came many times to train our anesthesiologists how to do it, because at that time intraoperative neuromonitoring wasn't available and wasn't accepted well in Bulgaria. And also Dr. Dira Anatna Krishnan, she did not only surgeries and teaching, but also make a good contact with companies to supply us with necessary implants for this program meetings. In the beginning, many neglected cases, as could be expected, severe deformities were treated, and it was a great experience for us as a local surgeons. I mean, to see how to approach and how to treat such patients. This is a picture just for example, one of the, I would say, many cases in this condition. It's 136-degree idiopathic with a very rigid curve. I'm not attaching bendings because this is not the purpose of the presentation. And the local team was trained with significant improvement of skills and knowledge, and also available equipment. And in 2009, local team started the first independent surgeries in Bulgaria. National health insurers started to finance the implants, more or less pushed by our activities. The number of cases increased by every year, and nowadays we have up to 50 cases per year of pediatric deformity people, children, patients. What else? Moreover, the local team introduced some innovative techniques and approaches for the first time within the country and even within the region. Nowadays, we are working according to the international standards, routinely using, and I'll say compulsory using intraoperative neuromonitoring, having opportunity to use a hollow gravity traction in all variances. Since the last month, we have even navigation from a leading company. We are doing 3D printing. We're able to do 3D printing, and we're doing this for some of our very complicated or challenging cases. It helps a lot for improving your technique and shortening the surgical time. Nowadays, techniques that we have in use, we're doing posterior fusion based on selective approach, as already was mentioned by previous speaker. We could do all of the osteotomies or almost all of them. Anterior techniques, we have available VBT in Bulgaria. We are still very carefully planning to use it due to, we believe that the indication to use VBT are very specific and they have to be followed. Otherwise, still the reports for complication rates is too high in our understanding, but maybe the surgery will go in this direction. We are able to treat the whole spectrum of pediatric deformities, and just to give some examples, we have more than 150 idiopathics with, these are some results just to illustrate the cases. Some very complex congenitals, as an example, a child 1 year and 2 months with this complex congenital deformity was treated with a vector technique, which is specially designed for this kind of patients. Neurofibromatosis cases, example, 4 year of age children, we treat with magnetically controlled rod, which gives us a chance to distract without surgery during the child is growing. Neuromuscular cases. Before starting this program in Bulgaria, was believed that the neuromuscular cases are not good for surgery because the risk is too high and so on and so on. Nowadays, we are doing surgeries of all of these children that are requiring this kind of surgery. Syndromic cases, another good example, 126 scoliosis, but just pay attention on a sagittal balance. We did magic rods. I'm mostly happy with the sagittal result, and we distract the child. And just to finish, I would say the result of all this program and all of these years, the goal of the SRS program is achieved, I can say it. It's a great example for international cooperation. I really appreciate this help that was given to us from SRS. The impact of the quality of the care for these children with spinal deformities in Bulgaria is more than significant. It's changed dramatically after the actions done by SRS, this SRS program. All contemporary implants become available nowadays and financed by National Health.
Put your jacket in here.
Which is very important. And we have back the trust of the patients. Patients become believers. So in conclusion, we believe the health service given in Bulgaria is comparable with the same service given in the countries from the Western Europe and even USA. And moreover, we have patients from neighbor countries or even living in Western Europe that are coming for consultation and treatment in Bulgaria. And finally, to say, as a host and local surgeon, and from the name of the Bulgarian children with scoliosis, I would like to express all of our gratitude to SRS and to all of the participants in this international program. Thank you for your attention.
Well, I think we're going to skip the questions again and for time constraints. Anyone that has questions, please type them in, we'll get them answered. And our last speaker is Ioanna Angelova, who is from Bulgaria and is 19 years old and was treated there with a posterior spinal fusion a few years ago. So, Ioanna.
Hi, for me. I'm Ioanna, and today I will share with you my personal story. I have been training in rhythmic gymnastics for more than 13 years. When I was 11, I found out that I had scoliosis. It was about 30 degrees then. My family and I immediately took action and started going to corrective gymnastics. A year later, when we did a control X-ray, there was no change in the degree of the deformation. Then the doctors recommended I include swimming and exercises. After all, the control X-ray showed that the degrees had progressed and had already risen above 40. Doctors recommended quitting rhythmic gymnastics and wearing a corset. I put on a corset, but I was adamant that I would not end my career. I wore a corset for 20 hours, and for the another 4, I trained. Despite our best efforts for 3 years, the curve continued to progress. I was 16 years old when I met Professor Yablanski for the first time. The curve had become 46-82 cup. He recommended surgery, posterior fusion, and also told me I must quit gymnastics. I was 17 years old. Once I had the date for the operation, everything happened very quickly. Hospital admission was on Monday. The team did all the necessary preoperative tests and X-rays that prepare for surgery on Wednesday. By the end of the week, strangely as it might sound, I was able to walk around. However, I was not ready to give up rhythmic gymnastics and say that was not an option for me and would continue after the surgery. Against all odds, a year after the surgery, I won a gold medal. Thanks to the incredible specialists, 100% dedicated to their work, namely the entire team of Professor Yablanski, this dream of mine has come true. Professor Yablanski, so glad I didn't listen.
That's Joanna, that was an amazing story to be able to go back to that level of gymnastics after a surgery. How soon after your surgery did Dr. Yablanski let you go back to start doing your routines? Vasco?
Ioanna, do you want me to help with translation?
Yes.
Доктор Clements пита колко време след операцията съм ти разрешил да започнеш гимнастика отново.
Ами, по принцип не ми разрешихте, но аз започнах една година след операцията.
Okay, David, she said she started actively to do gymnastics 1 year after the surgery, actively as a sport.
So you had her wait for a whole year before she could start again?
Actually, I told her, I do not recommend her to go back to the gymnastics. I told her that she has to quit, she has to finish. And of course, I recommend to choose some less active sports to replace or something. She didn't listen to me. And it was not expected even for me that she will won this competition, which is a great success after the spinal fusion. The gymnastics, you know, they're very competitive for winning.
Could you ask Joanna what was the biggest thing that she was afraid of before the surgery?
Ioanna, от какво беше най-много оплашена преди хирургията?
Честно казано, аз не бях изплашена, тъй като още от малка знаех, че ще се стигне до операция и някакси през годините се настройвах за това.
She said she wasn't afraid because she knew that this time will come during the years, and she was very well prepared for the surgery. Actually, she was expecting to have a surgery at some moment.
And could you ask her, how surprised was she to win the gold medal?
Колко изненадана беше, че спечели златен медал?
Много. Бях много щастлива, че отново се състезавам и че успях да преодолея себе си.
She was extremely happy. She was extremely happy to compete again with the team because she's playing gymnastics, and she was very happy to be back and to win and to be so strong to take that challenge again to go back to this sport.
So thank you, Vasco, and thank you, Joanna. Vasco, please tell her how grateful we are that she could present this very inspiring story of going back to her passion, even having had scoliosis surgery.
I will tell her, David.
Thank you, Vasco. So next we'll have Dr. Shufflebarger close it out for us and give us a summary. Thank you.
Thanks, David. We appreciate all who were in attendance over Europe and the United States, and I trust that you take home several messages from this. We'd like to call your attention to the sponsor of this, the Setting Scoliosis Straight Foundation. If you are grateful for the event, we would very much appreciate receiving a donation of any size to the Setting Scoliosis Straight Foundation. You can go to the website and do that, and this will help with future patient education events. So thank all our presenters and the organizers, and we'll close the program on that note. We do want to give thanks to our several industry sponsors as noted, and we will have several more educational events the rest of 2022. There will be a survey to follow. We'd like to hear from you.